Kindly mute yourself. Yeah.
Chala sir, shall we start?
Yes, please go ahead, Harish.
Yes, sir. So as we know,
Recording starts. Oh,
as we know, being a surgeon,
Started, sir.
practice, more than a practicing a surgery, without ethics is not a vital part of our practice. So we realized as a surgeon that ethics is the most vital part of our day-to-day practice. So being a cream of the society, we should bound to that. So that's why today, with the continuation of the last session, session one in the surgical ethics in surgery, we are continuing with the session two with the eminent speaker. So I welcome Dr. Lakshman sir on behalf of Surgical Society and all the moderator panelists for the today's program. So please proceed, Dr. Lakshman sir.
Thank you very much, Harish, Venkat. Thank you for the opportunity. We are in the second of the 3 programs SSB had planned for ethics surgery. We have just one change from the panel of the last session, which was held a week ago. Mrs. Nirmala Murthy, who is a very accomplished health care related person, is with us today, and a very warm welcome to you, ma'am. She is a doctorate from Harvard, has been a faculty at IIM Ahmedabad, and is a founder of the Foundation for Research in Healthcare, and I know that she is very active in some of the ethical committees of institutions which actually scrutinize and allow or disallow studies that need to be done. So she is very actively involved in the field of ethics in healthcare, and even though she said she had some reservations, we have absolutely no reservations about the fact that she is the right person for her role here. She will be representing the patient's point of view in the discussion. As you know, the legal aspect is going to be discussed by Dr. Joga Rao, who is a pioneer in the field of medico-legal issues. He started the medico-legal course at the National Law School in Bangalore, and he presently anchors the professional activities at a firm called the Legal Excel Attorneys. Welcome to you, sir.
Thank you.
We have our own 2 surgeons, Dr. Sopimat, who has served as the past president of KSASI, who is a very active and popular surgeon and endoscopist at Hubli, and Dr. Rajgopal Shenoy, who is the professor of surgery at Manipal, excellent sought after teacher, author of very popular and highly used textbooks in surgery. And if you see, particularly after the webinar, I'm sure he was active even earlier, but now I see that he is flooded with these offers for speaking at one form or the other, and I don't know how he manages all that, but we are very glad that he is with us today. A few ground rules for people who might have joined this time and missed the last time. These are repetitions. Please keep yourself muted. We may not be able to, the subject is very vast, so we may not be able to cover everything and answer all your questions, but put them in the chat box. I will be looking at it, my colleagues will be looking at it, and so you will get answers in the chat box. I request our panelists also, when they have a minute, to look at the chat box, and if they feel like giving their answer, please type it in. A subject like ethics, disagreements are inevitable, and it should be so, because that's why you have a discussion. But all the disagreements may please be very civil and muted, and that is very, very important. And I must go on record to say that the last session was exemplary. People were extremely nice, they had different points of view, but the discussion was actually excellent. As I said, some of the points may go uncovered. Please don't feel bad if I stop you, because we have a time bound program. So we will have to finish maybe in about 70 minutes, and if it goes at the most, we will definitely stop at 90 minutes. So if you have comments, please keep them very short, be crisp with your questions, and I request the panelists and the audience to be equally short, and brevity is the essence of good answers, I think. So please keep it short and brief. We start off right away with our first question. Like the last time, what we have is a set of questions. We pose it to the panel first, and then we involve the audience also. And if you really want to chip in, please raise your hand. We will try and accommodate you. But more than raising the hand, I think putting your comment in the chat box would be preferable. And once we get some basic issues sorted out, I will show you some evidence-based thoughts on the subject, and we will give you real life scenarios. Of course, it is anonymized. Nobody knows where or who it was, but these are very true incidents which have happened to doctors over a period of time. So if I may involve our lady panelist first. Ma'am, what defines a good doctor-patient relationship?
You're starting on the wrong foot, but because I thought you're going to tell us about the cases and we then respond, but okay. Luckily, personally, I haven't had much experience with surgeons personally or in the family. So let me give you a little more imaginary response to this question. I would have liked it to be a little more personal, but I don't. I think I saw your slides, and you have captured most of these decisions. What is the relationship between doctor and patient? What is it patient is expecting from doctor? Of course, he is expecting cure. He wants a treatment. He wants trust. He wants he wants to be very cared for, and of course respect if you can give, but he's not expecting the respect. He's expecting a good treatment. And so the relationship between the patient and doctor is in our ethics language would be do no harm. So he expects that the doctor will not harm me. He will tell me that he will, to the extent possible, tell me what the truth is, to the extent I can bear it. And he expects that he will not make me anxious. Anxiety would be reduced. So he would be kind, he would be caring. And if something goes wrong, I mean, I do expect as a patient that because I gone there, I'm not well, so something may go wrong. But if something goes wrong, then he would be there, he or she would be there to care for me, that I will not be forgotten. Those
Very
are the
nice.
4 or 5
Very nice. You mentioned about trust, you mentioned about respect, you expect about truthfulness. Very nice. Sopimat?
Yeah, I think Madam has nicely mentioned about all the points. I would rather say that it varies. Of course, the ingredients are more or less the same, but it remains more or less a little variable based on what kind of patient comes to me. For example, if it is a very illiterate coming from a village and all that, he expects me to take care of him as a whole. He says, you do whatever you want, but do something good to me because I come back. It's a kind of immense faith what they pose in us. And I have to make good decisions, explaining them in whatever language they can understand with a bare minimum. Try to understand them, pros and cons, and go ahead. Suppose if it is the other way around, if it is a little more educated patient, all that, I want them to be partners in my thinking and my problems also. Suppose if there is a confusion, suppose if there is something, if I have options, I want them to be partners in that so that we work together.
Yeah, whether they are literate or not, would you give them this choice first, or would you assess them and make a decision yourself?
No, I in the initial itself, of course, they do express, what kind of role I have to play. Depending on their way of expression, I take that, I change that role. It is the body language, the kind of language they communicate to me indirectly, that what role they expect me to play in that given scenario. Based on that, I choose that what role I should play.
Dr. Rajan makes the point that it is simple. The relationship must be courteous both ways. Rajgopal, your comments, please.
Thank you, Dr. Lakshman. Dr. Hess, he was the former president of American, Physicians Association. In one of the addresses, he says, Almighty, has given one of the biggest responsibility on doctors. He has created a life, no doubt, but the repair of this body, he has handed over to us. So there is nothing greater reward than this. And if you want to do it successfully, there should be an excellent patient-doctor relationship.
Yeah.
As rightly put by other speakers now, it starts from day one, first time when you see the patient. As and when he comes inside, we try to understand him. We develop some kind of a trust. It's a mutual trust. Patient who comes to us will expose their parts. We know their disease. We have to be so much careful about that. That means patient has full trust with us. Patient should try to understand us, and we should try to understand them. As Dr. Sopimat put it, the whatever literacy and other things.
Yeah.
There should be, patient should also know what is your skill, my skill, what is my skill, so that I also should tell the patient that this is what I can't do it. So you go to others. So basically, a combination of all this will develop into a good doctor-patient relationship. That's
all right. Dr. Jogarov?
Yeah, doctor, I think that the kind of relationship must have the foundation of mutual trust, integrity, dignity in rendering treatment, particularly along with cordial and purposeful communication with the patient.
Very nice. I think you actually hit the nail on the head. And the commonly mentioned points are that there must be trust, there must be respect, there must be honesty. Please note the operative word is mutual. The operative word is mutual. It's not a one-way traffic, and there must be confidentiality. All right. So I'll give you real life scenarios, and I would like all of you to respond to that as to what we should be doing with this. Now, it happens to all of us all the time. Patient comes and sits next to you and starts talking about it. You examine him and you start saying that, look, I need to get some routine, I talk about the possible diagnosis perhaps, and then the need for investigations. I tell him, I need to get some blood tests done. So from the right pocket, he takes out and gives you, sir, I had these tests done last week. So he's gone elsewhere, and he's what we in our jargon call shopping. So he's come to me and he gives me the blood tests. Okay, I patiently look at it. And next I say, look, you need a scan done. So from the left pocket he takes out, sir, I had gone there somewhere else 2 weeks ago and this is my scan report. All right. Similarly, it comes across that this patient is actually testing you out rather than coming to you for an opinion and giving us bits and pieces of information. And our question at that point in time is, what is the kind of trust he is having in us? Would it be wrong for us to say, look, you trust me, tell me that you have been to 1 or 2 places before, give me all those reports and then ask for an opinion, we are happy with it. What should be the doctor's approach in this? Sopimat.
Yeah, I have a little different approach. I did experience this in the beginning, but now I have formulated something different altogether, a step in clinical examination. When they come inside, they usually come with reports, bags, whatever it is, what you said. Some of them may be visible, not visible. I request actually my staff themselves outside, they say them, keep all the reports date-wise arranged. And when they come inside, they keep all those reports on one side.
Suppose they don't give it to you at that time.
Then I think I'll tell them politely, look, suppose first time it's okay, first report, second report he takes out anything. If you have any other reports, please put them all together. I just gently put that
Rajgopal?
at that time. Yeah.
I understand that India is such a country of 130 crores or plus, such a huge population country, whereas some kind of a governance or administration rules, what I'm trying to tell is, there are several here. So a patient who gets some abdominal pain will go to some place and gets ultrasound done, it comes to you, fine. Now your question is, he may not tell you, that is your question.
Correct. Getting things done elsewhere is not an issue at all.
Not an issue. So
why is it not revealed at the beginning of your interview? Is my
yeah, it may be due to 2 reasons. One, maybe patient is ignorant about it, that I should tell you. Second thing is, patient may think that we may get upset. Why did you go there? This is another question which normally told by the whoever, the surgeon or physician, whoever it is.
Yeah.
And last but not the least, with the, of course, today we talk about Google knowledge, this knowledge, that knowledge. Patient also might have come to also maybe testing your knowledge.
Yeah.
I am not sure about that, but in general, if I see patients coming with the reports, I never criticize them or I never talk anything against. I just, okay, I will go through it and I will give up.
That is the message I was looking for. Sophie, you wanted to say something?
Yeah, no, usually these patients, when they come to us, another reason why it doesn't happen with me is that we don't ask them for reports right from beginning. See, in fact, there is my staff tell them outside itself that do not talk about reports. Do not talk about previous opinions. You just tell about your problems. Doctor will definitely ask you at certain point of time that you should show them a report. Because I don't want them to bias with me that I went there, he told me like this, I went here, I got this test and this report says like this. That biases my thinking. So that is a standard instructions given to most of my patients of late. Do not talk about reports, do not talk about opinions, just tell about your problems. Later on, your time will come to reveal the reports.
Mrs. Murthy?
Yeah.
Well, from the patient's point of view, I mean, this is, he has come to the specialist and the surgeon almost after maybe going to 2-3 other people and have done the test. And he expects that all this will be seen by patient, because that's why he has still come to a problem, because problem hasn't been solved. So he wants to see that the doctor has seen. That's part of the trust, in fact, as far as from the patient's point of view.
Let me put it this way. It is not that the patient has told you that these things were done and that he is seeking another opinion.
Yes.
That is the crucial difference. We would love it. We have no problems. But I'm asking my colleagues and I'm asking you, if the patient doesn't say up front that he has had interviews or consultations with others, would that indicate some degree of lack of trust in you, or is it okay?
Not to me. I wouldn't see it as a lack of trust. I would see
Dr.
it
Jogaro?
Yeah.
Doctor, irrespective of the literacy background, etc., I would expect a patient to be fair and prudent. Suppose if I have consulted someone, I have done, upfront it is better, it is desirable to share with the doctor and say, in the light of this, I am approaching you, and whatever you say, I will take into consideration and take an informed decision. That's what I think.
Yeah. See, the message I wanted to go out was, this is common practice. Just for my younger colleagues, the point I'm making is that you should not be upset. Don't take it as a lack of trust. It is our culture. It's in our culture that we don't come up front and say things to people because they have so many complex ideas in their minds. Don't get upset. Put it aside. You and do your job as a professional. That was the kind of message I wanted to go out.
Perfect.
Okay. Yeah. The second thing about this is about communication. It happens to me and many endoscopists. We would have very clearly said that when you come for an endoscopy, you should come on an empty stomach. Very simple. I'm not talking about big informed consent. We'll talk about it later. Okay, somebody has to come on an empty stomach. We give them, in fact, a written instruction to that effect. And they take milk or this or that, may eat, and then come for an endoscopy. And of course, we ask them at that time, are you on an empty stomach? I've had instances when they have said yes, and after I put an endoscope in, I have discovered food in the stomach. But many of them say, look, I've had it, so I've had to put off my examination. And somebody else very happily claims, the relative or sometimes the patient himself, nothing was told to us about it. Now, is this a lack of perception? Is it a deficiency in our communication? Honestly, as I said, we give a written communication, and before that we verbally say so. What is it that has to be done, or should we dismiss it as another cultural thing and leave it at that? Mrs. Murthy.
The tendency, probably, and my own experience in that, if people are very anxious during that, probability of forgetting is very high. Also, interpretation of don't take anything. Does that mean water is okay, milk is okay, there are people who say, okay, milk is not okay, but ice cream is okay, and that's the level of anxiety and lack of understanding there is. So, and of course, victim blaming, just like people have tendency to say, I was not at fault, you have not told me.
Right.
Written instruction, our students also don't read. So I do not know. There is a real problem.
Correct.
And not to get
perturbed by it. That was the message. So these things happen in everyday practice, but society expects a higher degree of patience from doctors, and they have to be very patient about these things. Manish makes the point that it is better to give the benefit of doubt to the patient. That is about the previous thing, to the patient, as they are not clear about how to discuss issues. Yes, point well taken. Rajan, I'm sure, says the 7 C's of communication: clear, coherent, complete, concise, concrete, correct, and courteous. Rajan, rest assured that these things would have been done. But I want our youngsters to note that in spite of all this, some things may happen and they should not be really perturbed about it. Now, the very interesting thing about the patient relationship, again, they say there should be no manipulation, there should be no intimidation on the part of the patient, and there should be no condescension. You should not be condescending towards a patient. You must treat him as an equal, and it is understood that you have better knowledge because you are the professional. That must be humanistic. There must be a very human value attached to it, with respect and trust and belief in the patient. Also understand, we have already touched on this before, the patient is in trouble. He is very anxious and apprehensive, so you don't expect him to have normal reactions that you would have in a restaurant when you're talking about something, about politics. This is a different kind of an interview. All right. So before I go to the next question, I see Sopi with his hand up. Can you?
Yeah, it is about the trust, mutual trust we talked about, good patient relationship. Such patient, if he does it first time out of ignorance without knowing the consequences, fine, I'll explain him again. But sometimes what happens is this behavior is seen consistently with some group of patients. That raises little caution in me that I need to be more careful in documenting whatever explained, talk and all. Because these are the patients, if something goes wrong, you never told us, you never explained us, that kind of thing. So this is a trait which I would be a little more cautious in dealing with such patients in documentation, and making one person who has got better IQ or understanding responsible when I talk to them. I make sure that person is there every time I talk to them as a family.
Yeah. Yes. All right. Good. Now, we're talking about a humanistic approach. We said no intimidation, no manipulation. Okay. But we also say that there must be complete truth in your communication. Okay. So if you are talking to them about, say, recurrence of a hernia or possibility of bile leak, these are complications, bleeding, bile leak, when you're doing a laparoscopy, for example, remote possibility of bowel damage. Now, if we say these things in an informed consent, would that be intimidation, Dr. Jogarao?
To my mind, it is not. In fact, on the contrary, as per the Supreme Court's judgment, what is required to be disclosed to the patient takes within its fold this particular information. The only thing is the doctor is expected to consider the underlying condition of the patient and take note of the way it requires to be communicated.
Yeah.
That's the one.
Yeah. Mrs. Murthy, my concern is this, we say it in a very nice way, it's actually remote, and we say that we have to say it because they need to be aware of it. But what does the patient expect from you? When I have had patients who tell me, I have come to you with this problem and I came with the expectation that you would reassure me and do everything fine without any problems, but you're talking about possible problems. Why is it, doctor? How do I answer that?
Yeah, this comes in basically that anxiety and our expectation that doctor is God and he is going to solve my problem. So that's how the patient comes. I have always felt that even though we say doctor and patient equal relationship, it cannot be, because there is a knowledge difference. You cannot expect doctor and patient to be similar. But there can be some other person whom he trusts, like a family doctor or a patient, a family member who is a doctor, or somebody with whom you can deal with, give him that impression, which can be then communicated to the patient more gently, because gentleness is needed.
Yeah.
And the probability, saying the remote probability, 5% probability, then he says, okay, 5% probability, I understand.
Yeah.
So a little discouragement, but he needs also another person whom he can trust, who can bring the relationship in
So have
balance.
a buddy, have somebody else along with the
Yeah,
person.
yeah, balance is needed.
Yeah. This is a very contentious issue. I would not like to dwell too much on it, because it'll take away the focus of the evening's discussion. We have talked about apprehension, we have talked about anxiety and the reaction of patients. We can't expect it to be as normal as somewhere else. But my question is, should we accept, we would like everybody to be very brief, because I know this itself can go on for a long time. Very brief. Should we accept the widespread verbal and physical abuse of doctors? Should we ascribe it to anxiety and then condone it, or should we be very strict? The government, the law, and the healthcare profession, should we be strict with it? Rajgopal.
Yeah, just before I answer this, I just want to say that for the previous question about that gallstone issue.
Yeah.
See, that is the most commonly done surgery, and if I have seen that one surgeon told that you will come in the morning, you will get it operated, tomorrow you go home.
Yeah.
And this is what is the bill.
Yeah.
See, the problem is, and consent has been written and they have signed.
Yeah.
But that has not been told to the patient of the injuries and what you said. That is the actual time these problems will happen. So what I understand is that at least the expected 1 or 2 common complications we need to tell, rather than going on talking about the 30 complications or 25 complications and scaring away the patient from you. That is what is my take for that.
Yeah.
Into this,
can we come back to this now and talk about very briefly, should we have deal with a very light hand this big problem of physical and verbal abuse of doctors?
This time I definitely consider that we should be, should have a lot of patience, number one, as if possible, try to take the help of other group of people to involve in this in such a way communication, so that you need to cool down this patient or a patient party or somebody, because they might have lost their whoever it is, kith and kin or whatever it is. Yeah. So I believe that adverse outcomes, this can be probably avoided if you are to inform the patient before surgery itself. This is what can happen to your whatever related. That's my takes.
Yeah. Venkat, can I bring you in? Do you have any comments on this, please? Venkat, are you there?
Hello.
Yeah. Go on, Venkat. Your audio is...
Hello.
Yeah. Go on, please. Go on. I think there is some bandwidth problem, Venkat, so we'll have to leave it at that. Can I bring in Dr. Sheshgir Rao, please?
I'm audible, sir.
You're audible now.
Yeah.
Go on, please.
See, sir, the issue here is that
we are losing you again, Venkat. Connection problems, please. Yeah, it is intermittent. Go ahead. And if it breaks again, then we will go to somebody else. Please go ahead.
No problem. So the issue here is that when we are doing any surgery, whatever is the extent of surgery, the complications must be explained, whether it happens or not. We may quote some percentage.
Yeah.
Depending on the extent of the surgery, the severity of the disease. So, but communication has been made. Even the medical legal experts will agree that if you miss one complication and it happens, then
Yeah, we will. Yeah, we are losing you, Venkat. We are losing you again. We will come to that. Yeah.
Is the main
Yeah, Venkat, I'll have
problem
to
that
leave you there. I'll have to
yes.
leave you there because there's a connection problem, and that is coming later on. That is coming on later on in greater detail. Dr. Sheshgir Rao, can you come in, please? Okay. Dr.
No
Sheshgir
problem,
Rao,
sir.
can you come?
Yes, sir. Yes,
Yeah.
sir. Sir, actually, because I'm working in a government setup
Yeah.
where we have a lot of patients who are means quite poor and illiterate, they come. For them, actually, thing is, we tell them few things about the surgery because, like for example, for a lap chole being converted, or there's few things because if you tell them more about the all the complications, they may not know and they may run away fearing the things.
Yeah.
And we have to give them proper concern, listening to them. See, I'll just give you a small example what happened. So actually, we did a lap chole and patient was supposed to get discharged on day 2. They said they wanted to check up their eyes. They wanted to stay for 2 more days. She went for eye checkup on the 5th day. There she had an MI or something. She collapsed and she expired actually. The problem is we all went there and we told them, then the children and all, they were so happy. It means actually they never made any big issue out of it. Sir, you did a lot of things. You told us to go on 2nd day, but we wanted to
So
show
we are
it's not your
looking at
problem.
sir, we are looking at a
Yeah.
situation
Yeah.
where that doesn't happen. So
Yeah.
my question, my case 13, my question is, should we, when the patients and their relatives or their relatives throw these abuses at you, should you quietly condone them because they are anxious and apprehensive, or should we take action? There is a law against it, so should we then lodge a police complaint? That's my question.
I think thing is, if it's, I think you should, we should lodge the complaint, sir. But not that the thing is because all these things happen in such a short interval that many times we may not be able to stop the incidents.
All
But
right.
at least few things. Yeah.
Jogarao, what's your take on that, please?
Yeah. One important development in this regard that has taken place just 2 days back is a public interest litigation petition has been filed before Karnataka High Court, seeking much more detailed protection, legal protection, the kind of context you are referring to. Now, coming to the issue, in my opinion, verbal or physical abuse under no circumstances can be justified, particularly in the light of the law, what is being enforced. And I don't think it is to be condoned by the doctor or the management, considering the anxiety on the part of the patient. If at all it is done, I think it would tantamount to encouraging people in similar circumstances to undertake such kind of thing, which I think is not in the interest of it.
All right. Thank you. Thank you. We will quickly move on because, as I said, this will definitely attract a lot of discussion. We'll then have to go on to some unusual situations of consultations. That's another area which all of us must be aware of. These include, informal social setting, private care with financial issues, which is, 75% of our health care is in the private sector, and very understandably people have to come. The government setup cannot deal with all the all the required healthcare responsibilities, and so they necessarily have to come to private care, and they have no money. They will run out of money, for example, or they have no money at all. So what should be done? That's the kind of discussion I would like. And of course, phone calls and friendly questions that happen, and what are its legal implications afterwards. These are the things that I have. This happens to many people. Somebody comes to invite you. You are a surgeon. They come to invite you to their son's wedding, and they keep saying, "Oh, by the way, I have this abdominal pain, and I have this, I have that. So what do you think, doctor?" And because he's a friend, because he's come to your house, you don't feel like saying, "Come and meet me in my clinic." You probably give him some advice, and that advice may be inadequate because you really haven't examined him properly, haven't done the necessary thing. What should be the doctor's approach at such a situation? Mrs. Murthy.
Oh, no. I cannot tell what the doctor's advice.
No, as a patient,
As
do
a
you think a
patient to
patient
advise.
asking for this kind of advice, is it correct or not?
No, it is not correct.
Not correct. Yeah,
In
okay.
fact, whenever I see this happen, I tell people, no, this is not. You cannot ask doctor. This is like management. I cannot get my companies to work by by visiting somebody else. So
Right.
no, it's not correct.
Rajgopal?
How does doctor very politely tell him is a question which I don't like.
That I'm posing to Rajgopal. What would he do if he got a situation like
If I get a situation, I probably will answer patient problems, but with the rider, because that suppose a lady is having a specific problems related to her incision or a breast or whatever it is. Obviously, I can't do it in a examination in wherever it is. It is. See, what happens is many times our patients are not everyone is rich or not everyone is educated. They have their own problems. They would have come as a great respect to you to invite to whatever the marriage. In the bargain of one of the family members may be having a small problem. So, in other words, if it can be managed, like in COVID times, how many we have managed over the phone? Hundreds of calls we have managed over the phone. How it was possible? Why not we put it in the same thing in this setting also? This is how I take it. But
right.
with the rider telling that, yes, this is only a temporary suggestion, whatever I am giving. In case if it doesn't improve, you have to. That's my.
All right. Kalaivani, what have you to say?
I would, similar things I would say, sir. I will just answer them very in a simple way, and I would tell for details, please come to the clinic and I will examine you in detail and explain to you in detail.
Yeah, that's exactly what I do. I'll tell them a few things, but tell them that it is very inadequate and I may not be doing them justice. Instead of saying, don't irritate me, I say, look, I may not be doing you justice by this, so please call on me in my clinic. That's what I would do. I hope that message is clear to all our youngsters here. Okay. Now, this is something which we really need to discuss because this is a very common issue. A genuine patient, we all, we know that he is well-meaning, he respects you, he has trust, you have trust, everything is fine. Surgery is expensive, particularly tests and the operation theatre. He just cannot afford. We briefly touched on it last time when Sopimat mentioned how he would write off his fee and try to get the management to see if they can cut some fees and things like that. Now, what I am interested in is saying the doctor can do only that much. The management also has its responsibilities. It has to meet its expenses in setting up that healthcare setup. Collectively, what can society do about it is my question. Sophie, you have your hand up.
No, I just wanted to make a point here that I give them alternatives. Where it can be done at a very reasonable rate and all that, and if they still want me to do, that's what I would. This is how I would help you out within my limitation.
Yeah.
And I think I had a discussion with you where you had mentioned about some trusts and everything and all that who are willing to help and all that. I recollect that.
Correct.
And I think if that comes in future, if you can utilize that, that would be a great idea. Yes.
Yeah. Dr. Sanjay Jain, can you come in, sir? What are your comments about this?
Yes, sir.
Yeah.
Basically, nowadays, so many schemes are available from the government, and I think it will be a good time to help them with all of them, and especially in the government setups. We are able to help out so many patients with, like, we have Ayushman Bharat scheme or some kind of that, the financial constraints they go up.
Yeah, yeah. Very nice. Let me involve a youngster, Nishant, what have you to say about this? He is just starting his career as a surgeon. How would he approach this problem? Are you there? Nishant? Okay, Himagirish mentions that it should be crowdfunding in the case of patients who can't afford the fees. Yes, that is one option. Sophie, your comments again, your hand is up.
No, I just wanted to tell you one or two incidents where it has happened when the surgeries are not an emergencies or anything like that, where it can elective and all that. I suggest them they go back, get enrolled in one of these schemes and or something like that, and then come back after a certain time.
All right.
That's another thing which I do.
Yeah. One of the things that one can do in private practice, which we have been practicing, is yes, without question, the professional fee is completely written off. The hospital may not be able to give complete concession, but they are requested to give some concession. They probably write off 25% of their fees that is announced or published, and the rest of it can come through philanthropic trusts. We are lucky to have access to certain trusts of people who have kept money, and so we take money from that and pay the hospital fee, so that the patient doesn't pay anything at all or very little from his pocket. And that is one model that has been working for us for many years, and that's something one can consider. The other is a little more tricky one. I called it 15A. See, you put a patient on a ventilator. ICU care again is extremely expensive. You put them on a ventilator hoping that he will get better, maybe in a short time, 3 to 4 days, and things develop and he cannot get better in 3 to 4 days. You sort of have to prolong it for maybe 2, maybe 3 weeks, and the family puts its hand up and says, look, I cannot pay, you do what you want, I cannot pay, so I'm asking you to take the patient off the ventilator and leave it at that. This is a very tricky situation for a doctor. Dr. Jogarao.
I would prefer a voice of doctors to begin with.
All right. Okay. Can we get somebody from the audience? Dr. Kubsad, Shivanand Kubsad, he is one of our very senior surgeons working in the rural setup. Sir, what would you do in this situation? Dr. Kubsad there, please. I see him active on the chat box, but he doesn't seem to have. All right. Rajgopal, you start off, and by the time.
This is definitely a difficult question to answer, but as far as I'm concerned, I will first look at the age of the patient, number one.
Yeah.
I will look at the disease, nature of the disease, number two. I will look at the utility or usefulness of this man or a woman to the society or whatever it is. And then, of course, the other rules will apply, that hospital rules where I am working. This situation also we face in our institution, because ours is a private institution. Having some problems like this.
Yeah.
It's when it is beyond my control, as far as I try maximum communication in this situation.
Okay.
When it is not possible, I will bring it to the notice of the medical superintendent.
You leave it to the administrators. That's the message.
And time has come, 1 or 2 situations where there was a shifting of the patient.
Yeah.
Was done when patient started showing improvement. That's all I think.
All right. Manish, any comments? Manish, are you there? All right. Naz, can you come in, please? Dr. Naz?
Yes, sir, I'm there.
Sorry, Manish, go ahead. Yeah. Go on. You know the question.
Please continue, sir.
Sorry. The question is, you have somebody on a ventilator, the patient needs prolonged ventilation, and after 3 days, the family says, I'm sorry, I don't have the money to pay. And so he says, can you please, what do you do at that stage?
I've been quite pro-patient centric, so I try to do whatever best I can do in that institution, or I shift him to another institution, because the patient matters most.
All right. Okay. Dr. Kubsad is there. Sir, please come in and give your comments, sir.
My situation is different. I am owner of the hospital, and I am everything in the hospital. Suppose the patient is like this and the patient relatives do not want to pay for that. I tell to the patient relatives that I will just look after the patient for next 5 days, 6 days, whatever is there, without any fees.
Yeah.
And I have done in many cases. And we'll see what happens. Suppose the patient survives and goes home, I will ask them to pay if they want to pay. Otherwise, I will take it as a charity work and I will just continue.
All right. Dr. Jogarao.
Yes. let me just explain to you why I wanted to hear the voice of doctors. This is one issue which baffled even Honorable Supreme Court of India. And it continues to be so because the Honorable Supreme Court decision, in a way, is incomplete and inadequate. Maybe we will discuss in our third series of this particular workshop. But essentially, the problem is, I have two opinions. For example, if the doctor thinks, as a matter of clinical decision, that the patient is likely to improve 3 to 4 days, in such a case, I think doctor should adhere to what his or her clinical decision. Suppose if it prolongs and the kind of problem, etc., the popular practice that is invoking Dhamma, either referring, shifting the patient to home or something, that is what is a popular practice despite Supreme Court guidelines, because the manner in which the Honorable Supreme Court has decided, I think is very, very difficult to follow in practice.
Right. So the message is that the doctor must continue with his clinical decision and help the patient in every way possible. And as my honorable colleagues mentioned, if it is impossible to continue in the institution where you are practicing, perhaps find a place for him elsewhere. Dr. Srinivas sir, Dr. DKS is my mentor, and he was the chief of the curriculum cell. Srinivas sir.
Thank you for, am I audible?
Yes, you are, sir.
Thank you for giving this. I'm talking from the patient's relative point of view, because I faced such a situation. And as Dr. Raj Gopal said earlier, taking into consideration the age of the patient and other things, I decided that my father, I requested the doctors to remove from the ventilator. Because that was a harsh decision.
That was a different situation. We're talking about financial issues in a person who will do well. So that's a slightly different thing.
Thank you. I'll come.
Sophie, last comment from you.
I beg to differ from Professor Jogara's opinion that, in his opinion, that just because of financial issue, you cannot shift the patient back home. The Supreme Court, I think that is about withdrawing or withholding treatment in a terminally ill patient. That's a scenario is different. This scenario is different. I think Supreme Court has not touched upon the issue where you cannot, this situation where the patient is unable to get, the patient is on ventilator. We do not know whether he will survive or not, whether he will improve or not. I think shifting home would not be an acceptable thing. The patient who is on ventilator, at least. I think there are two things. One thing is involve as Professor Shania has said, involve the administration and the legal thing. And in the worst scenario, you have exhausted with your charity, everything and all that, then you can shift him to an institute where probably the treatment would be free. I think that would be a better option by a medical attendant on a ventilator. I think you cannot meet the expenses. There is no way that the administration agrees. I think this would be a better option than shifting him back to the home.
Yeah, but I'm not quite sure Jogarov said that you shift him home. So do you want to come in and...
I want to clarify
that.
Yes. Dr. Sopimat, I did not say that, doctor.
Okay.
It's a popular practice. That's not
okay.
Second thing is, Supreme Court judgment, what you said is correct. But here the context says only patient on ventilator. But ventilator on account of a particular, that the context doesn't define. Therefore, I mentioned.
Yeah.
That's
okay.
Yes.
Okay.
Agrees.
Yeah. And so, generally, please note that a doctor-patient relationship transcends social, economic status, and fiscal considerations. That is a very important thing. And the message, I think, came across quite clearly, that when you have started looking after a patient, you can't wash your hands off. Whatever the situation, do the very best you can to complete the treatment in whatever way possible. There are ways, you have to spend time and find those ways. Now, we then go on to the very important question of informed consent, because most medical legal issues come because of difficulties, I would call it that. I wouldn't call it deficiencies, but difficulties with informed consent. And I'll make a few common comments about it and then come on to the clinical scenario. First, we must know that it is a shared decision. Completely respect patient's autonomy. We discussed it last time, that among the 4 pillars of ethics, autonomy is now taking a preeminent position. It does help a doctor-patient relationship. Your compliance is better, and it is known that the recovery of patients who have gone through a proper informed consent process is better, and the mental health of the doctor who follows this emotional health is also better. These are all evidence-based publications. And the pillars of an informed consent are that you must explain the disease, what it is, the choice of treatment available, including a non-surgical treatment if it's available, the risks involved, the consequences of non-treatment. If you do nothing, what happens? And in case you have any kind of conflict of interest, that has to be mentioned. If you're using a mesh for a hernia repair and you have shares in the company that produces those meshes, then it is expected of you to talk about a conflict of interest there. All right, these are the basics, and let us take it that all of us do this very, very nicely. Okay, we have understood it. All of us doctors do it very nicely. But then you have real practical issues, and that's what I'm trying to address here. You have a case of pancreas cancer, and you have a patient who comes, it need not be a villager, it could be anybody, who is completely unaware of either what pancreas is or what cancer is. All right, how can you possibly say I'll make him understand and get an informed consent? Mrs. Murthy.
You mean he is aware even if you will explain to him the disease? I mean, is he mentally not capable of?
He is mentally quite capable, ma'am, but he doesn't understand that pancreas is an organ in the body, where it is, what it does. You try to explain to him, it doesn't get across to him. He doesn't understand that cancer is a potentially fatal disease and it has certain characteristics that grows somewhere. It can metastasize, give some problems elsewhere, and it's a potentially fatal disease. He just doesn't comprehend that. All right, what would you do in that stage?
Well, if he doesn't understand, I always depend on somebody who he trusts and can understand.
Exactly.
Because you need somebody like that.
Correct.
My mother doesn't understand, but then I would have to be there.
Yeah.
That's what I would do to see that he has that kind of understanding.
Rajgopal, you have anything else to add?
Last time we did mention that somewhere, if women or men, carcinoma pancreas is authorized somebody, or we can tell the patient that, see, you can't understand this, so at least I will talk to somebody whom you have trust. But adding on to what madam said, I would like to try my level best with some pictures, which I told last time also.
Yes.
And very, very often, madam, what we call as illiterate or uneducated, they do have some kind of understanding. If we can explain to them at the way in which they can immediately think back and say, okay, this is how it is, and this is what you are going to do me, this is what is going to happen. Most of the time they will agree with you what you say. But one important point here is, I consider that everybody should not consider this informed consent as a form to sign, like bank. We go and sign 20 or 30 signatures. A language which patient can understand and communicate, we can communicate. That's what is my take.
Naz, what have you to say? Are you there, Dr. Naz? All right. Maybe she is not there. So what the point I was trying to make, I brought it up again here, you're quite right, Rajgopal, was to make 2 or 3 important points. One, spend time with the patient. It cannot be a form filling process. Spend time with the patient. Have the patients to explain a few things about what pancreas is in their language. And if you don't know their language well enough, get a buddy, get a relative whom he trusts and mention it, and as you rightly said, draw pictures and they will definitely understand. And at the end of the day, give them a gist of this, that this is a potentially life-threatening problem. It needs a major operation to correct, and then that itself forms a part of an informed consent. Yes,
Can I?
ma'am.
I'm sorry. Just that's why I asked you in the beginning. If the
Yeah.
patient is not capable, if he is a mentally
No,
retarded person, that's not the person.
This is not. We are looking at a patient who knows.
Patient who is
who's with it, but doesn't have even the basic medical knowledge. We do see them. Surprisingly, we do see them. Now, this is a very straightforward issue, but it has happened in clinical practice, and one of our friends wanted this question raised. The patient with a pregnant lady with acute appendicitis, she's quite ill with it, and she's in pain. She knows what it is. Accept surgery that is required. But the mother-in-law, as you know, who is very scared about the possibility of an abortion during surgery, doesn't want it, because she wants her grandchild to be risk-free, not realizing that in fact even the process of acute appendicitis getting worse can actually cause abortion. Now, what should be the doctor's approach in this? Sopimat.
Yeah, see, here the patient's life is very important, and the outcome of mother is very, very important than the child. So, and I would value the patient's opinion more than the mother-in-law's opinion, and I will try to convince the mother. After that, with all other methods, I will try to convince the mother-in-law that she has to accept it.
Himagirish?
Yes.
Can you unmute and come in, please?
Sure, sir. Thanks a lot. Thanks a lot for calling me in.
Yeah.
It's quite an honor. Maybe we have to educate the mother-in-law about the risks of not going ahead with the surgery. And maybe if we kind of get her to realize that it is in the best interest of her daughter-in-law to, as well as the baby, for her daughter-in-law to go ahead with the surgery, I guess everybody wins then.
Yeah. The point I'm making here is that patient's autonomy is supreme.
Yes.
So if the patient says go ahead, nothing else matters.
But really, what happened to the husband?
Well, we didn't talk about
Bring him in.
Okay, but these things happen, and so yes, you have to try and, as Sopimat rightly said, try and educate people, and you will be able to go through with it. But please note, this is an adult patient. Autonomy is important, and if you suggest and she agrees, you go ahead with the surgery. Okay. Now, this is another common problem that we have. We talked about choice of treatment in an informed consent. Please understand, I'm looking at the different steps of informed consent. There is a choice of treatment that you have to give. Allopaths genuinely believe that unless it is an extremely sort of limited indication which applies to 2 to 3% of patients, tablets do not work for gallstones. The current gold standard is surgery. So we recommend surgery. But being where we are, being India, there is a lot of things about parallel medicine, what we call parallel medicine. For many people, it is mainstream medicine. It could be a homeopathy, it could be allopathy, it could be Unani. And the patient asks you, you are an allopath, you recommended surgery. He says, I've heard of people getting cured with homeopathy. What should be my reaction? Sopi.
This is a very, very, very common scenario and day-to-day scenario. I express my ignorance about any other alternate medicine. That's the number one. I say I cannot comment. I do not know about the effectiveness of the other system of therapy and the treatment. I can talk about my system of therapy. That's number one. And number two, in case if they still want to go ahead, and they can give it a try. I won't say outright that no.
Will they take it as your endorsement of the treatment?
No. I say that if you want to try, it's left to you. Yeah. But I wouldn't suggest it because I have no knowledge about that.
All right.
So, that's
Dr. Prakash, please come in, sir. Unmute yourself and come in, sir. He's not there. Rajan, are you back? No. Okay. Rajgopal, you had your hand up.
Yeah. All the things which Dr. Sopimat mentioned, I fully agree that. Only other small point I would like to mention is that I will not degrade any alternate form of the treatment or doctor. So what means to say that I'm telling that if patient says, I would like to take Ayurvedic medicine or something, I will tell it is left to you to take. They will ask you, is it good? Is it bad? Is it having steroids? These are the very common things. I say, I do not know. That's what I will not degrade any form of. That's what it is.
Right. Himagirish, you have your hand up.
Yes, sir. Thank you. Yeah, one question. Let's say the patient comes and the patient wants to go and try homeopathy. We explain our position. Of course, obviously, we are not authorities on homeopathy and other fields, so obviously we cannot, we will not reject it. Let's say the patient goes and something, worse. The patient does worse. She gets into a complication. What is my legal and social liability in that case?
All right, Jogarao, please come in, please.
In terms of social liability, there is nothing, because as a doctor, you have explained and you gave the choice to the patient, which he or she has chosen it. That's fine. In terms of legal liability, it is equally nil, because your treatment has never resulted in the kind of thing. That's it.
Yeah, yeah. Is it correct, without degrading any other systems? That point is well taken that Rajgopal made. But I'm sure all of us have seen people come up with complications of gallstones, for example. Having taken, parallel medicine, they come up with pancreatitis, come up with cholangitis and things like that. When these things happen, is it correct or incorrect on the part of a surgeon to say that he has seen these kinds of complications, but the final decision is left to you, the patient? Is it correct to say that, or does it amount to degrading another system? Rajgopal.
This is a difficult question to answer.
Only difficult questions. Yes, that's why I asked.
But if I am fairly convinced, I should be getting convinced that so and so has taken this type of a medicine. If they only, I will be able to give my opinion. Otherwise, again, my answer is I do not know.
Right. Prakash sir, do you want to come in? And we called you earlier, but we couldn't reach you. Tell me, sir.
Yes, sir. I totally agree with Dr. Rajgopal Shenoy. We cannot degrade any other system, but we should give liberty to the patients to have the choice to choose whatever he wants to. And you should say that any of the complication arises because of that alternate medication or alternate system of medicine. We're not going to help respond. That point should make it clear to the patient before he jumps onto the alternate system.
All right.
He should come back again to us and say, this you didn't advise us, or this may be because of the treatment already you have given to us.
Yeah. So you're going to say, yeah, you can do what you want, but if there are any problems, please don't blame me. That's what you're going to say.
Don't blame me for the treatment which already I have given to you.
All right.
Through my system of medication.
All right. Mrs. Murthy?
Yeah, it's a very good question. And nowadays we do talk about multiple treatment and different possibilities. And it's also important for us to know about other systems of medicine. As somebody was saying, what about, is the treatment going to be by quack? So at least can I help them to know who is a good homeopath or good treatment, or that somebody who they are going to is not a quack? So knowing a little bit about why that person is wanting to go to which homeopath.
Your final comment on this question, please.
Nothing to add. Everything has been covered.
All right. Okay. Now, consequence of no treatment. This is another really tricky thing. Everybody knows sorry, I missed that hand of Sophie Mats. Please go ahead before I start this question, Sophie.
No, nothing else. About what you mentioned,
yeah.
I read the comments also in the chat box that should we threat? No, I think we should not threaten with the complication.
Yeah.
But I think there is no harm in making a subtle hint that I have seen in 1 or 2 cases like this, a subtle hint, because we have seen that whatever medicines they try, ultimately it is going to be thin out the gallstones, and with the assumption that they will pass out. But we know what all complications can set in when the gallstones become thinner and they pass through the CBD. So I gave a very subtle hint that it is just my observation. It's left to you.
Yeah.
It's not a threat, the direct threat like.
All right. Manish, I have noted your question. I'll put it to the panel very soon. The next thing is, if you're totally honest about appendicitis, most of us recommend removal of appendix for appendicitis. The truth is that 85% of appendicitis patients settle with antibiotics. Why are we recommending surgery then? 15% get into complications, and we don't want them to have these complications, and the surgery is very safe. Again, 40 to 60% get recurrent pain and recurrent trouble. It can play up any other time in future at an unspecified time. These are the clear-cut statistics from the literature. All right. So when this is the case, are we justified in saying that the consequences of no treatment can be problematic when it is only 15% of complications and 40%, only 40%, perhaps sometimes it's 40 to 60, have recurrences? Mrs. Murthy, what have you to say about this?
The statistics you have presented shows that may not be recommending surgery immediately, may not be necessary because the person can have antibiotic. But then there must be, the person must know that when this recurrence occurs, or when something is very severe, that he can reach the treatment within the hours that are provided.
All right. All right. Kalaivani, what have you to say, please?
Depending on what stage it is, if it can be managed conservatively, yes, I will always plan for a conservative. But then, depending on how severe it is, definitely surgery will be advanced.
All right. Ramakrishna?
Good evening, sir. Sir, the 40%, 15%, they apply to the whole population. If do 1,000 surgery, probably it holds good. For the patient, it is 1% or 0%. If he develops, and I don't want to take that risk, so definitely I would advise surgery, sir.
All right. So the point I was trying to make is that, you know, even though you're very honest, you talk of these kinds of you know, discussion with the patient. There are issues where you will be confused yourself if you go into it deep. So the best thing is to make it a shared decision. When I recommend surgery, I actually quote these in a manner that the patient understands. I recommend surgery and I tell them why I recommend surgery, and almost always they take my advice. And that is the kind of approach that will be the safest, I think, for all of us.
Absolutely.
All right. And now the question is, you know, we take an informed consent. We have said all this. We talked about describing complications. There's that, everything. And when a problem occurs, the patient turns back and says, I was not told about this at all. We have a problem. So what is adequate disclosure is an issue. And literature is actually a little divided in this. It says it is difficult to define. Every single thing that you say can be contested in a court of law. And the naysayers again say, if you keep on talking about you know, complete exposure, you start with death. You know, people can die of anesthesia. They can die of even spinal anesthesia, if not general. You know, anything can happen. So you can't start from there. It is impractical. It increases anxiety. Alternatives confuse the patient. And in fact, if you keep talking about it, they may refuse the treatment and harm themselves. These are the naysayers for adequate disclosure clause. And so the general consensus, and I would of course lay it open to the panel and the audience later, is to describe the procedure in layman's terms, mention common complications, mention grave complications, and document the possibility of unknown complications. You may say that the list that you have given is not a comprehensive list, and there could be others that you do not know, that you have not mentioned at that particular time. Arvind, before I go to the case scenario, if you could come in, please. I see your hand up.
Actually, I just wanted to tell my personal this thing. 3 times I had right iliac fossa pain. I was doing post-graduation. I asked Dr. Bodhial. Every time he used to say, take antibiotics, and it used to subside because I used to take very early. 4th time when it came, I said, I want surgery. I am not here to do surgery for appendix. You have to write that you need surgery. So this is the sentence he told. I asked him to do it. It was almost pre-gangrenous or partially gangrenous appendix.
Okay.
So just wanted to
all right.
tell about that.
Okay. See, you know, this is a very very unusual situation, but it does happen to doctors at times. You see a patient, rectal growth, you can put a finger in and you know what it is. You take a biopsy and you suspect a cancer. You say so to the patient, but the biopsy comes back negative. It says it's either inconclusive or it's not cancer. You can't believe it, really, because you're clinically convinced that it is a cancer, and you can't just leave it like that. And so you recommend a repeat biopsy, and the patient goes away and says, "You never mentioned that this would happen." I don't think, he in his view, we are very inefficient, and we have not done things properly, and we have not even mentioned this possibility. Now, in your list of adequate disclosure, should a negative biopsy be included or not, is the question. Manish, are you there?
Yes, sir, I'm there. We'll have to just lay it out as transparent as possible, keeping our inclinations of possibilities.
Yeah. All right. Okay. Ramakrishna, can you come in again and say what you have to say?
Sir, usually I don't tell this possibility to the patients, sir, because it is quite rare. When it happens, I will try to explain. This can happen sometimes, and most of the time patients would agree.
Yeah.
Or at the most, they will go to some other doctor and get it repeated.
All right.
And in the informed consent, I don't mention this, sir.
Yeah. Okay. So the point I'm making is it's very, very unlikely if an odd patient does feel bad and does feel uncomfortable with what you have done. I think so be it. Jogarav, you have anything to add?
Just one aspect. The Supreme Court judgment, Justice Ravindran did take note of the possible dilemma on the part of the doctor. That is the reason why he mentions there is no need to explain remote or theoretical risks involved, which may frighten or confuse a patient and result in refusal of consent for the necessary treatment. Similarly, there is no need to explain the remote or theoretical risks of refusal to take treatment, which may persuade a patient to undergo a fanciful or unnecessary treatment. I think that's where he brings in the doctor's autonomy.
Yeah.
As the other doctor very rightly pointed out, because it is very rare, I think there is no need to include negative biopsy in terms of adequacy of disclosure.
All right. Thank you. All right. We have finished that part of the informed consent, but there's one issue, that important issue that Manish Joshi has raised. Now, it is very common for surgery is a discipline which needs the involvement of many people. One person doesn't do it. It's a team that works, and it is common practice when there's a team for consent to be taken as, the doctor explaining, Dr. Lakshman and team, Dr. Manish Joshi and team. Now, I will bring in Dr. Jogarao in this. Is that enough to say that, some part of the treatment, be it a little part of the surgery or be it a little part of the post-op care or whatever, is done by the team and not necessarily by the leader of the team, which many patients seem to expect, because, after all, they have approached the leader, the senior, they are paying him, particularly in private practice. Is it right for the doctor to expect the patient to accept treatment from the team and not entirely by himself?
I would advise the doctor's name along with other members of the team.
Right.
That is what is expected.
Okay. All right. Manish, you have anything to say in that?
It's getting more and more into a group practice scenario. So, and a lot of us can manage, and a lot of us are qualified. But still, I think the primary consultant needs to take the lead role in communication and in post-op care as much as possible.
Yeah.
Otherwise, it will probably lead to an unhappy scenario.
All right. Okay. So, upfront, as I said, you take the consent as mentioned, the doctor's name and members of his team, and explain to the patient beforehand that, it is the whole team takes care of the patient. By and large, it seems to work reasonably well. We go to the next and the last part, the doctor-doctor relationship. I must say that we may overshoot by 5 to 10 minutes. We'll try to finish it in time. Now, this is a very important part of ethics as well, apart from the doctor-patient, doctor-doctor relationship. It is clearly said that you must treat a colleague as a friend, you must respect professional judgment, and you do everything you can to make sure that there is no question of trying to get that patient from another doctor to yourself, and that when patients come for second opinions, which many invariably do, it is only an opinion. You give your opinion and send the patient back to the primary doctor who gave the first opinion. And this is the thing I'm going to focus on. And from the patient's point of view, a second opinion is best initiated by the treating doctor himself. Correct. So that when there is something which is amiss, which he cannot, put his finger on, it's much better that way, so that the trust is sustained, and it does not mean lack of confidence in the treatment for the doctor. That's again, doctors must realize that, and we have touched on that point. And it must be supportive to the patient and not critical of the other doctor. That is particularly when complications occur. And we must all realize that there is more than one way of doing something correctly. Medicine is an imprecise science, medicine and surgery. And so it is very, very incorrect to say something that somebody else did was incorrect, was wrong. That's not something that is done and said, because you do not know exactly what happened in that situation. Okay, and so I would like maybe 5 minutes of discussion from my audience actually on this. Kalaivani, we'll go with you. Not there. Okay.
Sir, I'm here, sir.
Oh, you're there. Go on.
No, regarding what I'm not catching.
You are not listening to me. So you, being my young friend, you will be penalized. You will come back and talk about it.
Relationship or the
No,
second
I'm
one?
talking about second opinion. How should one look at second opinion? When somebody, I have done an operation, there is a complication, and the patient comes to you. How will you deal with it?
Yeah. First of all, we should first look into the situation exactly, what exactly has happened.
Yeah.
Be courteous.
Yeah.
And let us see and explain that such complications can happen with anybody, that includes me too.
Yeah.
Even if I had done, it could have happened. And moreover, we are unaware of the situation, what the primary doctor has faced at that time.
Yeah.
So it is difficult to comment, and this may be conveyed to the patient.
Yeah. Okay. Sophie?
Yeah, 1 second. I'm just coming in. This is a very, very tricky situation that we need to handle. I agree with Dr. Kalaivani. She has made a very valid point. At the same time, outrightly protecting a doctor when there is a gross negligence from his side is also not acceptable now. Earlier, I think there is a conflict or there is a change in the Hippocratic Oath compared to original Hippocratic Oath to the present one, and what NMC expects. If there is a gross negligence and if you still say that everything is done well, fine and all that, I think you may be held responsible if it is known that you are trying to protect a doctor. I would better say that fine, it is something which should not have happened, has happened, it might happen in my hand. That's what we keep telling also, that it can happen in my hand. And Dr. Kalaivani said that it can happen and we need to attend to you and we need to correct and move on. So that's what I think we need to go ahead. But we need to be a little more balanced in what to conceal, what to reveal, how to move forward so that nobody is put into trouble. At the same time, we are interested in the safe patient outcome.
You have to be truthful. You cannot actually be telling an untruth for whatever reason.
You have to balance.
Dr. Jogarao?
In my experience, what I noticed is in sizable number of situations, the complaint is followed because some other doctor made a mention about the earlier treatment.
Yes.
And not to mention, in fact, the subsequent doctor passes a judgment, and the patient hopes that he will get similar judgment from the court. I think that's the thing. I don't think it happens in every situation, but I think it is a problem which the profession has to address and respond.
That is the point I was trying to make, which was very eloquently made by Dr. Jogarao. While you don't have to tell a lie to protect somebody, a colleague or whatever, but please be very, very, very circumspect and very, very clear in your view that you do not throw any kind of negative remarks on a professional colleague, whatever be the case. Sopimat, your final remark.
I just wanted to make a point that, of course, what Dr. Nishant has mentioned, that's altogether a different issue. But in most of the scenario, when there is a complication which happens inadvertently and patients want our opinion and they say that they want to go to court, in fact, none of the complications, which I must say with pride that they have gone to court, because we say that it can happen, and I might give a certificate that this what I have treated, everything is transparent. But when they call me as an expert to give an opinion, it may not totally support you, because I'll tell just it can happen to anyone, just like me also, it has happened to him. So they are discouraged. So none of them have gone to court so far.
Yeah. So this answers Ramakrishna's question. When what do you do when you know the other doctor is wrong and you're treating the complications? You can be truthful about it, but don't mention that was wrong. You're just doing what you had to do when the patient came to you. All right. Now, the very last part of our discussion is about a junior and a senior's relationship. It's again a doctor-doctor relationship, but there is a hierarchy. There's a senior person, there's a junior person, there's a teacher, and there's a student. What should be the relationship? I actually had just a little bit on this, but then I had letters from one or two postgraduates, and so I added a little more on this. I'm going to say a few things, and then perhaps the audience and the panel can comment on that. I think a teacher and a junior's relationship is based on 3 pillars: trust, respect, and communication. The problem I see is in this respect and communication. Our culture again somehow feels that we can perhaps take the juniors a little casually. Having worked across 3 continents, I have the feeling that in India, when a junior comes across, it's nice that people, seniors love the junior. I'm not against it, but somehow they do not treat them as equals. They somehow feel that, after all, he's a junior, we can do that. Trust, I think, is pretty much there. That breaks down only when the duty of the junior is not carried out. Communication is another huge problem for me, because our juniors just don't open their mouths, and unless they communicate with the seniors, then they cannot expect the seniors to read their minds. And so I always urge, we don't ask questions in meetings, we never disagree with somebody. There is no place for that kind of passive listening in science, and surgery is a science. So communication has to improve, and both seniors and juniors must understand that everything is, I'm not talking about a legal contract, but an unsaid, unwritten contract, which must have these components. Your goals must be specific. At the end of 1 year, I will train you to do appendix, hernia, gallbladder independently. That's one specific. It should be measurable. Obviously, when I say this, I'm standing next to you, you will be able, it's measurable. You do it and show it to me, that, and show it to the world that you can do these operations. It must be achievable. So within 1 year of training, I cannot promise you that I'll see you through a Whipples. It's not possible. It must be relevant. You're going to be somewhere doing something, and so it must be relevant, and it must be time framed, which already mentioned. We say in 1 year I'll do it for you. It can't go on forever. I can't take 5 years to teach you appendectomy. So what happens is, without saying it as much, in your mind, both the teacher and the junior must have these so-called SMART goals before they get into this unwritten, unsaid contract, and that is a part of your training. And the teacher is a lot more, he's a mentor, he's a lot more than just giving you exams and teaching you. You're an educator, you're an ideator, you connect them. Networking is very important. We help the juniors meet with other surgeons, other people, which helps them in their career. You challenge the junior to do better and better, because many times juniors are very diffident. They don't even know that they can do these things, but you tell them you can do it and give them a confidence. You challenge them with bigger and bigger tasks, and they really do it. And a cheerleader, when something goes wrong, you're there supporting them to see that they're okay. These are not just theoretical. There's a lot written about it. None of us seems to read about it, but that is the kind of goals that one must have. And mentoring, particularly in surgery, goes beyond theory and practice. You have to be giving them career guidance and financial guidance and make sure that these youngsters blossom into very good surgeons. I gave a very brief overview of what it should be. I now lay it open. We're not very behind schedule, so we can have a 10-minute discussion. Let me get our layperson in first. Mrs. Murthy, does that sound reasonable to you?
Very much. I mean, that's what any teacher is expected to do in most of the fields now. We have the same thing in public health. We have the same thing in management. But I just question, since I was not a medical student myself, is there a scope for a lot of discussion among teacher and students, so that, like a case study, so that they get a practice of questioning and talking?
Plenty of it, ma'am. Plenty of it. In fact,
Plenty.
most
So
of the medical teaching is
yeah.
that. But our problem is that people don't question. We question them and they answer and we correct them and all that. But from the other side, from the student side, we don't see them actively participating. And that's what I'm trying to inculcate in them, that they should be questioning. Suppose I, as a teacher, say that this is the right thing. They do not look at the literature and say, sir, the literature says something else. Why are you doing this? I expect people to say that. I want them to, very nicely, not in any rude manner, challenge me if I'm wrong, so that I also learn from that. But that doesn't seem to happen. Jogarao?
Yes, I think this is something what, as a young teacher, when I joined National Law School way back in 1988, that's how my learning. In fact, I continue to be a teacher, but in the process, I learned a lot and continue to do. And particularly the role of mentoring is something fundamental. I fully agree.
All right. Sophie?
I think it's one thing is there is a change of culture and kind of mentor and mentor, that relation which is changing. And it depends on the mentor also. I recollect some teachers with whom I would be open and I would just say that, sir, this is given in this journal like this, that they would say, oh, very nice and all that. Whereas some people I would just be reserved and just dare not to open, because I could guess that probably they would not like it. It's a mutual kind of thing that's happened. And overall, probably there is a hesitancy creeping up in the students' mind now. Maybe their focus is different. Their thinking is different. I do not know. Or maybe their experience has been bad. I do not know the reasons what all is happening. But probably this is a mutual thing. The more you encourage them to ask, the more they would come out. The more you accept their opinion, which is different, and appreciate. Yes, I appreciate it. I think you have brought a nice out point, which is learning to me. Suppose if we say once in a while, probably they would come out more openly to criticize you.
All right. Can I bring in Dr. Aital, who is hand up, and after him, we will have 3 teachers from the audience talk about it, and then that would be the end of the session. Aital, please.
Good evening, sir. Dr. Lakshman, sir.
Good evening.
I personally feel it is a relationship between the teacher and the student.
Yeah.
It is how you treat and how you teach the student all depends upon that. How you get it from the student is that. My example is, since last 2 years I've taken as HOD of the Matas, I have got very good relation with the PGs. And the way you treat them and way you teach them is so different. So they give a good input outside. Even once they'll teach me night, they'll call me, tell sir, this has to be done today only. Though I will respect them and go and do it. So it all depends upon how you treat and how you this thing. And today, except for Calais, my student has done a whole gallbladder laparoscopy, though he's in say 3rd year. So what I'm trying to say is that the way you teach from the beginning, where you give the respect, it all depends, it reflects, and there'll be an open mind in respecting the teacher as well as the giving inputs, and we also, as you say, get benefited from that. That's what I feel, sir.
Raj Gopal?
Can you show that smart slide SMART? I just want to make 1 or 2 comments that it looks very easy, nice to see this goal, like specific, measurable, achievable, relevant time frame, but it is not possible to do it for several reasons. We can actually debate this point. or starting from the faculty to starting from the student, that you are mentoring somebody, and what kind of a student you are having, and what type of mentor you are having. That is one point I would like to mention at this juncture. So I agree that opportunities are plenty. I believe the teachers should be more than active. There's a proactive. Proactive, when I say that, doesn't matter if the student doesn't open his mouth. Let us create a situation that he will be asked to open his mouth and start discussing. Times have changed. There's a generation gap now. The younger students, most of the time, believe that the knowledge they can acquire from the several sources, not necessarily a teacher. There can be many sources with which they acquire the knowledge, including journals or whatever. So many. So there are some changes which are happening. By and large, if both student as well as the faculty do active roles, probably that is the purpose of this entire success story. That's all.
Dr. Prakash?
Yes, sir. I agree with Dr. Shanai, sir. Earlier days, when we were students, whatever the professor says, we have been listening honestly and been taking it in a positive sense. Present day students are not like that. So what I have been as HOD here past 5 years, what I learned is whatever the blunder they do, don't shout on the student and keep encouraging them in a positive way. Whatever little one step they did a good way, encourage that so that keep increasing his capacity to learn and also give positive vibrations so that he keep learning it. That's what my thing, sir.
Manish?
Thank you.
Sir, I was just looking at the example of the airline industry. The Korean aviation industry had multiple accidents, though they had the two pilot system in place, because the junior pilot would not voice out if there is any mishap or misadventure that he has recognized, but the senior pilot is not able to still comprehend. So there has been a culture shift there, and legislation has been brought in by the airline industry. And because of the black box reading, it is mandatory that all these mishaps are looked into and the number of errors are reduced. And in airline industry, the percentage of errors are less than 1%. The same thing cannot be said about medical errors or the student and teacher relationship, because it is individually, it depends on the individual teacher and the student. So if there is some kind of a legislation, I'm just thinking loud, that would help bring this process much more clearer.
Yeah. Okay, last two comments because you're running out of time. Kalaivani?
So I have one important point to say. First, we should remember that the PG students are adult learners. So we need to respect their views and then take them into confidence and make them learn. I feel it's in our hands to mold them to whatever we want the best out of them. At the same time, we also have to be strict. Like when I say, if you don't treat, you will not get an opportunity to even assist me. I'm very firm about that. At the same time, take care of them. And blunders, yes, scold them, shout at them, or whatever, discuss, but let it be away from the patients, not in front of the patients. I've heard some people telling, I'll hang you there. That's not right, I feel.
Right. Can I get one postgraduate to make the final comment? I cannot, from the participant list, I cannot make out who the postgraduate is, but can I get one of you to say? Will you volunteer?
Sir, Ajit here, sir.
Ajit, go on.
Sir, it was a nice session, sir. From
No. I'm talking about this mentoring and mentoring and
Yes, sir.
What is your view about that? Yeah.
Yes, sir. Sir, like we have mentioned that someone should be there to supervise, so that meant the student can learn under supervision rather than being on his own. And there should be effort from student side also. It should not be like spoon feeding like we used to have in schools.
Come prepared, as Kalaivani was saying.
Yes, sir.
All right. Okay. Ladies and gentlemen, I think you will all agree that we have had a fruitful discussion. It's been time. Next week, 5th August, is an extremely important topic, care of the terminally ill, and that is something where all of us have to be very clear, and I'm sure Dr. Jogarao will have a very, very important role to play in that, because I'm sure we have a lot to learn from him. As usual, I always thank you and thank the panelists and thank the SSB for participating, and I keep giving you these lovely, what I consider are lovely quotes from the Dalai Lama. He seems to have hit the nail on the head several times about his priorities, and he says, be kind whenever possible, and it is always possible. A lovely, lovely, simple quote. Thank you very much for the same. Please give me half a minute. As a protocol, we have to end with the national anthem, and give me a little time to get that organized. And please stand up when the national anthem is played.
Thank you, Lakshman sir. Thank you very much,
Thank
sir.
you. Thank you.
We want to thank our co-panelists, Professor Jogarao,
Yes.
Dr. Shanaik,
I mentioned it in
Murthy,
one
and
word,
of
the panel.
course you. Yeah, no, from our side, I just wanted to thank them for the excellent contribution from them and all other contributors.
Yeah.
Thank you.
So on behalf of Surgical Society, I thank all the panelists, sir, and it was a wonderful session. And I thank Dr. Lakshman sir for his appreciable hard work behind this program.
Yeah. Are you seeing my?
Yes, sir.
Yeah. Did you see my panel and the whole thing?
Your video is
no, sir. The screen is not shared.
That is why I asked you. I didn't think my thing was shared. No. Is it shared now? Can you see?
Yeah, screen is
okay. I will play it now. It should be all right now. Yeah.
Still not seeing, sir.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधितरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मन जय हे जय हे जय हे
Ladies and gentlemen, thank you and good night.